Actress Jennie Jacques interviews Dr. Peter Rowe on orthostatic intolerance.
Good morning.
Hi, Dr. Peter Rowe. How are you today?
I'm good, thanks. How about you?
Honestly, I'm not great. I did put some mascara on, lay down, so that made me feel a bit better about myself.
There you go.
Got something here called Make Visible. So it enables me to pace myself more effectively and measure things via the app, such as heart rate variability and heart rate.
Great.
So I didn't want to cancel. I'm desperate to talk to you. I've done my research, and you're a bit of an unsung hero. Um, and I just thought it'd be great to get something on record and any information that's helpful to others and myself, just
Yeah, sure.
to be out there and use my platform.
Great. No, thank you for doing that.
My reason for wanting to talk to you is that you've essentially put on the map the link between orthostatic intolerance and ME. I might just use OI for orthostatic intolerance instead of trying to say it, and ME for myalgic encephalomyelitis.
That's fine by me. Yeah. Thank you for having me, Jenny. I'm Peter Rowe. I'm a professor of pediatrics at Johns Hopkins University School of Medicine. I'm a general pediatrician by training, and for the past 30 years or so, we've been working on ME and a number of the physical contributors to symptoms, including the difficulty people have getting blood flow to the brain when they're upright, which comes under the term orthostatic intolerance. We first brought to people's attention the idea that joint hypermobility was also connected with both the orthostatic intolerance and the ME. And then we've focused more recently on some of the biomechanical factors that can contribute to symptoms in the illness. I've been taking care of children, adolescents, and some young adults with ME/CFS since the early 90s. And that's been our focus on research since that time. So we are both clinicians and clinical researchers.
Some of the research I struggle to find papers on, and maybe you could help with this, is the interlink between hormones and orthostatic intolerance, and also just infectious disease itself, bacterial and viral, and the antibiotics that you might use to treat a bacterial infection. Can it make it worse?
So there's a fair bit of work showing, first of all, that women have orthostatic intolerance more than men. And so the hormones probably play some role. It's not incredibly well understood exactly how. But many of our patients start feeling worse right before their period begins. And that's the point of the menstrual cycle at which blood volume is at its lowest. That would then make orthostatic symptoms more common, like lightheadedness, fatigue, brain fog, all of the things that happen when you're not getting sufficient blood to the brain. And then people often feel worse for the duration of the period. And so one of the things that has emerged in the literature is that if you have recurrent fainting and are not responding to any other medication, some women respond to continuous birth control pills or some way of blocking the periods, such as with Depo-Provera. And so that work was published back in the 1990s. And we've used those insights regularly in treating our young female patients with ME as a way of making sure that their circulatory system is in better shape, that they're not having as many hormonal fluctuations. A corollary of that sort of emerged from the work on people who are transitioning from female to male is that when they get testosterone to treat the transgender state, they have improvements in their orthostatic intolerance. So this may be a hint as to why women get these orthostatic conditions more than men. Doesn't mean that we want to treat everybody with testosterone. That has too many side effects, but it gives you some physiologic insights. So that's a little bit of what we know about the hormones. In terms of infection, we know that these orthostatic disorders are often triggered by some form of infection, and ME has been linked to just about every type of infection known to man. And so that can be viruses, bacteria, Giardia infection, and obviously COVID. SARS-CoV-2 has been a huge contributor to the orthostatic intolerance. We have not recognized that very many antibiotics have a direct role, but there is one group of antibiotics that can cause a lot of toxicity. This isn't well understood or well known about, but the fluoroquinolone antibiotics that are often used for sinus infections and pneumonia and urinary tract infections can cause all sorts of havoc in the body. And people who have had toxic reactions to the fluoroquinolones will talk about floxing. So there's a lot of online and sort of less standard medical reporting about that. And some patients who have that kind of reaction to that class of antibiotics really get very ill. They can have all sorts of brand new psychiatric symptoms. It can be devastating. Thankfully, it's not super common, but it's also not well appreciated by the medical community yet.
Many antibiotics, including fluoroquinolones, were developed and approved in the 80s and 90s, based on research that is now dangerously outdated. Yet, modern medicine continues to rely on this decades-old data, despite mounting evidence of severe side effects like nerve damage, mitochondrial dysfunction, and chronic pain. This same system only abandoned graded exercise therapy in 2021 for treating myalgic encephalomyelitis, ME, a complex neuroimmunometabolic disease where exertion intolerance is a defining symptom.
But a different way that antibiotics could be associated temporarily with worsening of symptoms is if the person has mast cell activation syndrome, which is turning out to be much more common than we previously appreciated. Any infection can stir up the mast cells. You might think, oh, it's the antibiotics making me worse, but it could be just that the infection itself triggered aberrant release of mast cell substances that cause symptoms. And also that it could be that individual patients might also react to specific antibiotics. Like that's quite possible as well.
Yeah, and antibiotics, as wonderful as they can be, they do mess up your system, generally speaking. Like you then have to work on rebuilding your microbiome, etc.
We often find that when people have had a sinus infection, for example, their orthostatic symptoms are much worse, and it takes a while for them to get back to baseline. What we've learned to do in that setting is to give them an infusion of intravenous fluids, typically normal saline, and we give them 2 liters. Typically, most adolescents and adults will give them 2 liters over an hour to 2 hours. And then instead of about a 2-week downturn before they get back up to baseline, they get back up much more rapidly. So if you can restore the intravascular blood volume faster, it does something to reset the autonomic nervous system control of circulation. Our patients request that when they are just not recovering quickly from any kind of infection.
I do wish that that was more of a standard protocol here. The other thing, I suppose, similar to that is maybe having some sort of oxygen supplementation. One of the only things over the 7 years of me being unwell that has made a significant difference to my functionality is most likely hyperbaric oxygen therapy that I had at the Midlands Diving Centre a couple of years ago now. I really experimented quite hard with it. And really there were moments with that particular therapy that were almost miraculous. Unfortunately, I can't sustain it. Whatever is wrong with me, and I can't live in an oxygen tank as much as I'd love to.
Right. No, it's. I remember an older editorial about hyperbaric oxygen that it was a therapy in search of a disease, and so people have thought for a long time it would have to be helpful for certain conditions, but the number of formal studies of that on ME are minuscule. And in the United States, I don't know what it's like in the UK, but in the US, it was very expensive. So it was very hard to get any of these studies off the ground. But I know people have been interested in that for a long time. It may relate most obviously to the theory that the mitochondria are somehow dysfunctional in ME/CFS or related conditions like long COVID, and so it's possible that hyperbaric oxygen would be a treatment that we need to look at more closely. I think in formal studies because the anecdotes can be all over the place.
It is difficult, especially when you take something like myalgic encephalomyelitis, because a lot of the patients, just the concept of the journey to the tank, there and back, and being able to sit up in the chair with OI, because I had to lie down on the floor with it. I can't sit up for that long, even with an oxygen mask on, is implausible and might cause more PEM than it's worth. But for me, thankfully, I was able to do it lay down back to back for a long time. And it was wonderful. It really was, but not sustainable, which sort of made me ask you about the oxygen side of things. Because if you're mentioning the blood flow to the brain and the Doppler testing, which I'm really interested in, I thought, well, what's going wrong there with this oxygen not getting to the brain, and is the heart rate going high to naturally compensate for that? And then if we took a drug to lower the heart rate, is that a bad idea, because actually you want the blood to be going fast and get to the brain?
Yeah. So with regard to the hyperbaric oxygen treatment, one of the things that people use it for here is poor wound healing. If somebody's had a number of surgeries, for example, and it's very tough for the wounds to heal properly, that has been a helper. Yeah, with the orthostatic intolerance, there are several types, right? Sometimes we've often classified types of orthostatic intolerance based on what the heart rate is doing or the blood pressure is doing. But I think more importantly, and over time, as we get better tools to study this, it's really how much blood is getting to the brain. And patients who have a very fast heart rate sometimes do respond to a beta blocker drug or ivabradine to lower the heart rate. And that gives the heart more time to fill, so that can potentially, for some people, lead to improvements in blood getting to the brain. But it's fiddly. You really have to try several medications before you find a good fit in most of our patients.
That's fantastic. You've actually made me understand the mechanism much better. I think I just thought, oh, well, the heart has to beat really fast to get the oxygen to the brain. But that makes so much sense, and actually makes me feel a bit more optimistic about trying ivabradine. I haven't tried that. I was on pyridostigmine and Midrodine for quite a while. I sort of weaned off it and went more along the lines of using the hyperbaric, which was great but not sustainable. And more recently with it playing up again, I'm probably going to try the ivabradine. They're always so hard to say, these words, aren't they? I feel like it's a tongue twister.
Yeah, that one for sure. It works on something called the funny channel in the heart. So it works just on heart rate without affecting blood pressure. But why they called it the funny channel is a mystery. I wonder if the guys who first described it had been drinking a bit too much when they were writing their paper.
You can visit www.jenniejacques.com if you want to know more about hyperbaric oxygen therapy and my own experimenting.
People often ask me, what's your number one treatment for orthostatic intolerance? And I do not have an answer for that, other than that it depends on the individual we're treating, because people have different sorts of things that need to be addressed. But there are three big categories of treating orthostatic intolerance. One is that people who have this seem to dump a lot more blood into the lower half of the body when they're upright. We call it venous pooling. But there's just more blood outside of the heart and brain than you'd like. So there's excessive venous pooling. They also, for some reason, don't correct a low blood volume situation where people are about 10% less filled than they should be. And the body should have corrected that, but doesn't. So that's a paradox that we don't really understand. And then the third component that affects treatment is that once you've got those two things, excessive blood pooling in the lower half of the body, inadequate blood volume, then you're getting way less blood to the brain. And so there's an exaggerated response by the autonomic nervous system that involves high levels of catecholamines like adrenaline and noradrenaline being released. So to treat orthostatic intolerance, you can try to improve vessel constriction, venous constriction. You can try to improve blood volume, and you can try and block this excessive activity of the autonomic nervous system. So when we break it down that way, drugs that will improve venous constriction are things like Midodrine, as you mentioned, and the stimulant medications, Ritalin in this country. I don't know if it's known by Ritalin in the UK, but any of the stimulants used for treating attention deficit disorder are particularly good at vessel constriction. If you're looking at blood volume drugs, fludrocortisone or Florinef is one of the main ones, and there's several others. The birth control pills probably work for young women on blood volume. And then for the drugs that block the effects of the adrenaline, you've got beta blockers, you've got Mestinon, the pyridostigmine that you mentioned, and the Ivabradine as the main players in those areas.
This is a wealth of information to retain, and I cannot recommend Dr. Rowe's book enough. While primarily written to help patients and families, the book includes details on meds, dosage, and a reference list. Physicians, nurses, physical therapists, and other healthcare specialists should also find it really helpful.
So I was put on the Ritalin. I think it's called methylidate or something here, but I think it's the same thing.
Methylphenidate. Methylphenidate is the generic term, yeah.
Methylphenidate. So I was put on that, and unfortunately, when I gave my readings back, I was doing a titration, and they said, look, we can't continue this because your heart rate is too high, which was really disappointing because it really helped my sleep. Ironically, I thought it would make me, I didn't know what it was going to do, but yeah, it really helped my sleep, which again has its own knock-on effect. So I had to stop that, and it sort of made me go, look, you need to sort your heart out. Like, clearly you need to go back on some sort of medication to help the OI. And I wondered then, is it a case of looking at the non-stimulant ADHD drugs perhaps that treat both, or is it a case of that stimulant drug for the ADHD and a different drug that is for the OI, and sort of mixing them together?
Yeah, and generally, as a rule, we don't want to chase one drug's side effects with another drug. But if we're getting a really robust improvement from the stimulant, but it causes, say, a big reduction in appetite, which is a common side effect, or a lot of trouble with insomnia, we will often add in cyproheptadine, an older sedating antihistamine at night, because it has an appetite stimulating property. And while, again, you don't want to be chasing one drug's side effects with another drug, if the end balance is that the person is functional, who cares about the old rule? So you've got to be willing to kind of experiment with this. It may be that if you were on a drug that better controlled heart rate, you wouldn't have as much of an acceleration in heart rate with the stimulant, and then you could have better function, better cognitive activity, and for many of our patients, much better energy. So we're always trying to look at the imperfections that are associated with a given drug, but try to lessen their impact and really rely on the thing that is making that person better. Some of our patients have been told by their physicians, look, exercise is really important for treating the orthostatic intolerance, and therefore, until you show me that you're serious about exercising, I'm not going to give you a medication. And I liken that to saying to a child with asthma, look, you need to show me that you're working on this problem by running around the football field 4 times, then I'll think about giving you a puffer. We would regard that as complete insanity. And yet this idea that exercise is a cure still is prevalent.
Exercise is not a cure for ME and must be approached with extreme caution. Any attempts at movement for me have to be carefully monitored to ensure that I stay within my energy envelope. I need to avoid post-exertional malaise and prevent potential permanent damage. As someone at the milder end of this devastating illness, though it's still excruciatingly difficult to manage, I really wanted to approach Dr. Rowe responsibly about the possibility of using my lay-down pedals while in bed, without making myself worse.
Yeah, we want people to be able to exercise, but we have to support their circulation before we can ask them to do that. And so our experience over and over again has been that people who get really symptomatic when they do try to exercise, once we've got them on a good medication regimen, we don't need to cajole them to exercise. They increase their activity naturally because they want to do things again.
Dr. Peter Rowe couldn't be more correct. No one would need to cajole me to exercise. I will increase my activity naturally when I can, because I want to do things again, as do the millions of others missing with this horrific disease.
As for your reclining bike or in bed bicycling, there was an experiment ages ago that was done on astronauts, because the astronauts, when they were on zero gravity, would come back to Earth. And I remember as a child seeing the Gemini and Apollo capsules being pulled up out of the Pacific Ocean onto an aircraft carrier. And we were told that the astronauts were in quarantine for a week. And I thought, well, what did they catch in the sterile environment of outer space? Like, that doesn't sound right. Well, it wasn't an infectious quarantine. It was that they couldn't sit up and answer questions at a press conference until their blood pressure had been fixed. And so one of the studies that was done to try and understand this was that people were asked to go on complete bed rest, like not even getting up to the bathroom, for up to 200 days. I think that would be a recipe for becoming completely stark raving mad.
Okay, so I couldn't help myself here. If you know, I'm sorry you know. If you don't know, even minimal exertion on some days can cost me weeks and sometimes months in bed.
I think that would be a recipe for becoming completely stark raving mad. But what was really interesting is in the first 2 to 3 weeks of complete bed rest, people would lose about 15 to 18% of their blood volume. And if they then gave them a bike in bed to fiddle with and just pedal, it blunted that loss of blood volume. So it points out one of the things that's really important, which is that exercise eventually can help by building up more blood volume. You know, humans are in their best shape if they can move, obviously. The key is to find something that allows the person to tolerate the activity without getting post-exertional malaise. And finding that balance is tricky, as you know.
Ironically, if I look at the data on my phone, it's more stress on my body to go to the toilet or to sit at the table and try to eat, where my heart can go up to 140, just sat down. I'm not anxious or worried. I'm absolutely fine. And I have my legs up as well. I always have my legs up. I can't sit with them down.
We often notice that, you know, the kids come in and they're sitting like this in the chair, and we'll say, well, this is a very good position for you if you have orthostatic intolerance, because blood is not pooling in the lower half of the body as much. Your legs are squeezing the blood out. You're pushing it against the abdomen where some of the blood pools after eating. And I'll say, this is a very good position for you to reduce symptoms. And the kids will glare over at the parents and say, see, I told you, because inevitably there's been a fight about how you sit properly at the dinner table. And obviously they're not trying to be willfully disobedient. They're just trying to be free of symptoms.
You know, unfortunately, I can't go out in a wheelchair because I love, I love being outside. I was so active before I got sick, but the sitting in the wheelchair, it's more stressful on my body probably than walking a short distance with my stick, interestingly. Yeah. So it's so hard to manage an illness that really you need to be tied to a skateboard and slid around.
Right. No, but the just what you describe is classic, right? That many of our patients do better if they're in motion than if they're in a quiet position. And I think this is why many of our patients do better if they're walking than if they go to the shopping mall or if they go to a museum. And we joke with our trainees that if you've got an adolescent who can't go to the shopping mall because they can't tolerate it, you've got a real problem until proven otherwise.
Oh, yeah, of course. You know, people want to live. You have a thing in you that wants to create. It's ridiculous to think otherwise. In regards to the walking, though, as an example of this being such a horrible Rubik's Cube of a disease, I also can't walk very far because I'll get post-exertional malaise. And so even though the movement could be good for me in one way, it would zap all my energy in another. So, you know, most of the time, even having this conversation, it's going to take a lot of energy for me and I'm going to have to rest after it. And I'm just lay here. It's just insane.
Well, and it's just what I was talking about before, that that in your case, there would have to be some better control of heart rate and circulatory function in order for you to tolerate what you would like to be doing.
Yeah, and I'm still struggling 7 years down the line to find that, unless I do go and live in a hyperbaric oxygen tank, which I'm thinking about it. I'm serious. Or space, maybe. I think I might be allergic to gravity.
That is a very commonly used term, that this is a problem dealing with gravity.
Compression socks are really helpful, and they've been a bit of a blessing. I remember I sort of turned my nose up when the cardiologist mentioned them, so I just thought, I'm so ill, and you're telling me to put these silly socks on, like they're going to do anything, but they actually did really help.
Yeah. No, one thing that might be relevant, that is emerging in the literature is, we see these conditions that are not random, that occur together. So, for example, the joint hypermobility contributing to the orthostatic intolerance, also to the mast cell activation. And one of the things that you can get if you've got very stretchy, lax connective tissues is that the blood vessels can be compressed. So there's been some work showing that if you've got compression of the veins that are coming out of the leg, bringing blood back up to the heart, something called May-Thurner syndrome, or if women have pelvic congestion syndrome, where they have lots of varicose veins in the pelvis, they can have bladder urgency with that. And it can look like it might be interstitial cystitis or some sort of infectious thing. If you get the blood flowing better out of the legs by stenting the compressed veins, people report marked improvement elsewhere in things like pain, lightheadedness, even migraine symptoms. And so we're unsure exactly why you'd have such an improvement in other areas, but one of the ones that improves is also their bladder urgency. So as you said about the Rubik's Cube, you really have to chase down which of these other problems might somebody have as a contributor to their orthostatic intolerance.
Yeah, I did notice just through reading some of your stuff that you worked on a patient and you actually found out that the issue was in the neck. And again, that's another thing that I've read before.
Yeah, we've had a series of patients who had large bulging discs in the neck, in the vertebrae of the neck, and they were pressing on the front part of the spinal cord, and it took a while for anything on their neurologic examination to appear, but once it did, we checked an MRI and we saw this, and we have a colleague that does a disc replacement, so it's a lesser operation than a fusion of the vertebral segments. And the first patient went from being housebound for 4 years to being able to be a dog walker, to start in university. And she's now a foreign aid worker, doing really good work internationally. And all of her ME symptoms disappeared. Her postural tachycardia syndrome disappeared. And interestingly, a free-floating anxiety that she had also disappeared. So we used that observation, and the next patient had two bulging discs and was regarded as having a functional neurologic gait disorder, and they thought she was making everything up. But she had extremely brisk reflexes that you can't fake that. And so when she had her surgery, she went from being unable to do anything, moving back in with her parents, despite having had a job beforehand, to functioning independently again. And then the third patient was very similar, went from having full-blown ME/CFS symptoms and orthostatic intolerance to being able to ski again. And 3 or 4 years into her improvement from a single level disc replacement, she started getting her ME symptoms back and her lightheadedness back. And we thought, oh, what's going on here? When we repeated her imaging, her artificial disc metal thing had slipped. So it was now compressing the spinal cord just the way her disc had. And when that was fixed, she again had this improvement. So we saw in her case this recapitulation of the symptoms and a recapitulation of the improvement with proper surgical care. So we don't think this is a super common thing, but we hunt very carefully for patients who have a lot of neck pain or who have abnormalities on their neurologic examination, because these things can be mimics of ME.
while there's not an agreed official biomarker, everybody knows that ME itself is an umbrella term. And so the hunt is on. And I assume there could also be a combination of things wrong with somebody. It might not just be one thing causing the symptoms. The time's running out, and I would love to talk to you for much, much longer, but I think with my energy and obviously your time, we'll have to wrap it up. But it's brilliant. It's been lovely speaking to you. Thank you so much.
Well, thanks for bringing attention to these problems. You've got a big platform, and I think people just need to know that there are things you can do.
Oh, thank you. Thank you for the work you're doing as well.
Take care.
Bye.
Later.
I'm ending this with footage of me before ME. Exercise intolerance is underestimated. ME can be deadly. It kills. We know this, yet the monster continues to claim lives in silence. ME starves the brain of oxygen, making simple tasks like a telephone conversation or even me recording this voiceover exhausting and costly. I am so determined to support those left vulnerable and unable to recover from this condition. Since recording this interview, I have started Hyperbaric, and I'm happy to say I've seen immediate improvements in lowering my heart rate. Although my fatigue and mobility are still limited, it does feel like progress. I use electrolytes and salt to increase my blood volume while awaiting the potential addition of desmopressin. I plan to discuss this treatment combination for orthostatic intolerance in a follow-up with Dr. Rowe.